So now let's move on to peptic ulcer disease and Zollinger-Ellison syndrome. So peptic ulcer disease, the mechanism is decreased mucosal protection causing injury throughout the entire mucosa. You can have gastric ulcers or duodenal ulcers, and I'm going to create a chart now to talk about the differences between the two. So gastric ulcers are commonly caused by H. pylori, but they can also be caused by NSAIDs and bile reflux. Whereas duodenal ulcers, again, mostly caused by H. pylori, but a small percentage of them can be related to Zollinger-Ellison syndrome. Gastric ulcers have a classic pain pattern where people have epigastric pain that worsens with meals, and duodenal ulcers have the opposite, where they have epigastric pain that improves with meals. And so let's talk about why this is. Well, if this is your ulcer, like a gastric ulcer, and you have a normal amount of hydrogen ions, during meals, your body's going to produce more hydrogen ions, and that can cause inflammation to that ulcer, irritation, and pain. Duodenal ulcers, on the other hand, you can still have gastric acid secretion, but once it reaches the duodenum, you have a lot of bicarb being produced in your duodenum that can help neutralize that acid. And that bicarb is only going to come into play once you've eaten and the hormones have secreted bicarb for you. A cancer risk, it's important to realize which of these are more dangerous. So gastric ulcers have a high risk of cancer, so you do have to biopsy them, whereas duodenal ulcers are rarely malignant. And so benign, I don't know if they'll show you a picture, but it's good to know. Benign ulcers just look like a very well circumscribed hole, like a hole punch in your tissue. So it can look something like that, let's just say. Whereas a malignant gastric ulcer will look very, very bad. It'll be heaped up margins, larger, poorly defined borders. Let's talk about complications of each of these ulcers. So the first complication you have to consider is that either of these ulcers can cause an obstruction. And with duodenal ulcers specifically, you can actually get pancreatitis. So if you think about the pancreas, and we'll talk a lot about how the pancreas works in our pancreas lecture, you have these pancreatic enzymes that get released into the ducts, and these can go into the duodenum. Now, if you have an ulcer blocking off any part of that, then you might have a blockage and your enzymes will get stuck inside your pancreatic duct, and that can actually cause pancreatitis. It's important to realize that both of these ulcers have a risk of bleeding. So gastric ulcers tend to live on the lesser curvature and they bleed from the left gastric artery, whereas duodenal ulcers, especially posterior duodenal ulcers, they tend to bleed from the GDA, the gastroduodenal artery. So if here's our presentation, if you have a bleeding ulcer, it can present in a number of ways. It could be an acute, life-threatening bleed. Somebody could be coming in with signs of shock. They could have thrown up blood, or they could be just bleeding very bad, a bright red blood per rectum, like hematochezia. Or you can just have a slower bleed, like a more asymptomatic GI bleed. So gastric ulcers, it's located on the lesser curvature, and the bleeding artery you need to know is the left gastric. This is the same thing we showed earlier today, where you can have a bleed here, whereas posterior duodenal ulcers, they can bleed from the gastroduodenal artery, so you can have a bleed in this area. The last thing you need to realize is that gastric ulcers are associated with malignancy, which we've talked about a lot recently. And anterior duodenal ulcers have this risk of perforation, and they love to test this. So somebody who has anterior duodenal ulcer perforation, they're going to have severe epigastric abdominal pain. They're going to have rebound tenderness because now air and bowel contents can get directly into their cavity, the peritoneal cavity. And they're going to have shoulder pain referred from the diaphragm. On imaging, you're going to see something called pneumoperitoneum. So I'm going to talk about each of these things now. So pneumoperitoneum means there's air in the peritoneal cavity. And because air will travel upward, you're going to see this region right here where an air pocket gets trapped. and that's directly visible in X-ray. You should not see this. If you see this in somebody, that's pathognomonic for pneumoperitoneum. You also are going to realize they're going to have rebound tenderness from this pain, and they're going to have shoulder pain. And the shoulder pain is because this air is pushing against this diaphragm right here, and this diaphragm can have referred pain that goes all the way to the shoulder, and you'll notice pain there. Next thing I want to talk about, I talk about this as well in the pancreas section. It's the same lecture I used there, is Zollinger-Ellison Syndrome. This is a pancreatic islet cell tumor that secretes excessive gastrin. So we know gastrin is going to produce, gastrin is important for hydrogen ion secretion. So you're going to get acid hypersecretion, and that'll lead to recurrent ulcers in the distal duodenum or jejunum. And that's pretty rare if you think about it, because we have bicarb in our duodenum that should neutralize the acid, but there's just so much acid coming here that you can get damage to parts that would otherwise be neutralized by then. So remember that gastric ulcers are normally caused by H. pylori or NSAIDs, and you have to biopsy them because they could be malignant. Proximal duodenal ulcers, usually caused by H. pylori, like over 95%. But now, if you're looking at distal duodenal ulcers, you have to think about Zollinger-Ellison. And so how this works, if we have a gastrinoma right here, hypersecreting gastrin, that'll activate our parietal cells to produce a ton of hydrogen ions. And these hydrogen ions can make it all the way to the distal duodenum or proximal jejunum and create these ulcers in regions that would otherwise be spared. It presents like any other duodenal ulcer. That's going to be abdominal pain that improves with meals. So if you have a ton of acid and you have a ton of acid here, that would injure the ulcers in general. But remember, during times of feeding, you do have some bicarb that can help neutralize a lot of that acid, and that'll prevent most of the irritation to those ulcers. One of the ways to diagnose this is the secretin stimulation test. So secretin normally suppresses gastrin release, but gastrinomas don't care about secretin. They just keep doing their thing regardless. So how this works is that normally we have S cells in the duodenum that'll produce secretin. They'll act on the pancreas, and that's how we get our bicarb. It also helps us decrease our gastric acid secretion. So it's another way to help out in the battle, neutralizing some acid production. But the problem is that gastrinomas, if we have a gastrinoma here, producing gastrin and all this hydrogen ions, if you use secretin and try to inhibit gastrin release, it's not going to work. So you just have this steady supply of hydrogen ions. And I just want to point out, because it's a pancreatic islet cell tumor, Zollinger-Ellison syndrome is one of those tumors that's associated with MEN1 syndromes, okay? I talk about this in detail in the pancreas lecture. I just want you to know that our MEN1 syndromes are our 3 Ps. And right here, our pancreatic islet cell tumors include gastrinomas. Here's all 5 of our pancreatic islet cell tumors, and we talk about these in the pancreas lecture. Just wanted to point out that this is what we talk about there. Same thing as Zollinger-Ellison syndrome is a gastrinoma. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.